I would like to call to order the long-term healthcare special committee today, March the 13th. Madam Clerk, can you please call a roll?
Alderwoman Davis. Alderwoman Boyd.
Present.
Kathleen Holmes.
Present.
Harold Braswell.
Present.
Lenny Jones. Marjorie
Lenny
Moore.
won't be on.
Thank you. Marjorie Moore.
Present.
Laura Barrett.
Present.
Lavita Richardson.
Present.
Victoria Enruri. Andrew Lackey.
Present.
Annalise Stover.
Present.
Danielle Spradley. Chris Beckley. Tasanya Johnson. Jamie Opsel.
Present.
Cindy Jackson.
Present.
Ellen Usher. Ellen Usher. Reverend Kevin Anthony.
Present.
Alderwoman Middlebrook.
Present.
I'm sorry, Chair Middlebrook. Alderwoman Davis. Lenny Jones. Victoria Enruri. We have 15 present. We have a quorum.
Okay, thank you. What we're going to do next is, what was the last meeting? I'm sorry, Madam Clerk, where we can get approval of the minutes from January, was that January 30th? No, February 6th and January 30th, I'm
Yes,
sorry.
there's two of them that we wanted them to look over. The
Okay.
30th of January and the 6th of February.
Okay, if we could look over those for a second. And can I get a motion to approve the minutes?
I'll motion.
Second.
Second.
Thank you, Madam Clerk. Can you please call a roll for that?
Alderwoman Davis. Alderwoman Boyd.
Aye.
Kathleen Holmes.
Aye.
Harold Braswell.
Aye.
Lenny Jones. Marjorie Moore.
Aye.
Laura Barrett.
Aye.
Lavita Richardson.
Aye.
Victoria Enruri. Andrew Lackey.
Aye.
Annalise Stover.
Aye.
Danielle Spradley. Chris Beckley. Tasanya Johnson. Jamie Opsel.
Aye.
Cindy Jackson.
Aye.
Ellen Usher.
Aye.
Reverend Kevin Anthony. Chair Middlebrook.
Aye.
Alderwoman Davis. Lenny Jones. Victoria Enruri. Danielle Spradley. Chris Beckley. Tasanya Johnson. We have 13 aye votes.
Okay, thank you. So what we're going to do, we only have one item up today, and we're going to continue our discussion regarding long-term healthcare and the state of long-term healthcare. So we have three speakers today: Shelley Williamson, Tracy Niekamp, and Mark Unruh. Can we go ahead, Madam Clerk, and get all of them sworn in before we start?
Yes. Could you please raise your right hand for me? Okay, so I see Mark Unruh, I see Tracy Kneecap. I'm looking for Shelley
Shelley?
Williamson.
Sure. So Shelley is not able to attend. She has another meeting, but I can take over any questions that you have for her.
Okay, thank you.
Okay, sorry.
Okay, do you affirm that the testimony you are about to give in this cause will be the truth, the whole truth, and nothing but the truth?
I do.
Thank you.
Okay, so we will start with Mark. We can start with you, and we'll do about 10 minutes. If you have to take a little longer, that's fine. And then we'll get questions from the committee.
Okay, great. Should I go ahead and get started?
Yes, you can. Thank you.
Okay, thank you. Well, thank you very much for inviting me to speak about transparency and accountability in nursing home ownership today. I really appreciate the invitation. So I'm going to be focusing on nursing home acquisitions by private equity firms and real estate investment trusts. So these types of ownership are generally not transparent and have raised concerns among policymakers at all levels of government. This includes President Biden specifically addressing these types of ownership in the 2022 State of the Union address. Although I'm focusing on nursing home ownership by private equity firms and real estate investment trusts as examples, it's important to note that the issues I raise today may apply to other types of ownership as well. So let me start by providing a little background on private equity firms. So my colleagues and I estimate that about 11% of nursing homes in the US have private equity ownership, including some in Missouri, though I don't know the precise number in the state. But to make these acquisitions, private equity firms create a fund with a target amount for an investment. The firms then recruit investors that may include wealthy individuals, sovereign wealth funds, pension funds, even university endowments. So for these acquisitions, private equity firms generally use leverage buyouts. They contribute little of their own cash to the deal, maybe 10 or 20% of the overall value. The transactions are mainly financed through debt. The debt is then placed on the acquired nursing home and not the investors. That is, the nursing home is responsible for servicing the debt used to acquire it. So in regard to the goals of private equity firms investing in nursing homes, they seek to control a majority of the economic and voting interests. They tend to restructure the financial, governance, and operational characteristics to increase profits. And in general, they seek high annual returns, typically 20% or more annually. It's not clear how long private equity firms hold on to nursing homes before divesting. In other industries, it tends to be maybe 3 to 5 years. But these transactions are very difficult to track. They're not transparent at all. However, one study suggests that they tend to sell nursing homes after about 7.5 years on average. But the goal of high profits within a short time frame is what we believe differentiates private equity ownership from other types of for-profit nursing home owners. So we might ask, why do private equity firms target nursing homes? Well, first, we have an aging population that will need post-acute and long-term care provided in these facilities. There are relatively steady payments from Medicare and Medicaid, which provides most of the revenue for nursing homes. And most importantly, real estate. So real estate is the most valuable asset of a nursing home. Private equity firms often sell their real estate and disperse the proceeds to investors after they acquire a facility. So regardless, separating the real estate ownership from the operations shields investors from liability and also creates tax benefits. So in regard to the pros and cons of private equity acquisitions of nursing homes, there are some potential benefits. First, these firms provide management expertise. So you may think of your typical sort of mom and pop nursing home that when say someone calls in sick, they just go down the list and look for the next person who might be available. But if you have more sophisticated management systems, you might have software that identifies a person who you won't have to pay overtime to that week if you bring them in. Likewise, private equity firms often provide improvements to health information technology capabilities. They also have financial and legal resources to improve regulatory compliance. However, in terms of the potential cons of private equity ownership, as I mentioned earlier, there's pressure to generate high short-term profits that could lead to reductions in staffing, services, supply, or equipment. So just as a side note, staffing costs are typically about 50% of the overall cost of providing care in a nursing home. So that's often the first target. Also, as I mentioned earlier, nursing homes are often responsible for the debt used by the private equity firm as part of a leveraged buyout. Also, the private equity firm may not be experienced in nursing home care. They may just look at this as an investment. Additionally, it might focus on post-acute patients and less on long-stay residents because higher Medicare skilled nursing facility payments are much higher compared to Medicaid payments for long-term care. So in terms of research that my colleagues and I have conducted, our findings suggest that private equity investments in nursing homes are associated with increases in potentially preventable hospitalizations and emergency department visits, as well as higher healthcare costs to Medicare. And there have been other recent studies too that show a decline in the quality of care after acquisition. There are older studies though that have more mixed findings in terms of the impact on the quality of care, but they tended to focus on private equity acquisitions that occurred a decade or more ago before a lot of the activity really picked up in more recent years. So next I'll briefly discuss real estate investment trusts, also known as REITs. So if you hear me say REIT, that's what I'm referring to. But a REIT is a for-profit public or private corporation. REITs are pass-through entities that avoid double corporate taxation. That is, the REIT does not pay taxes on its profits, but the investors pay profits on the dividends that are paid to them. But in order to maintain this tax status, they're required to disperse 90% of their taxable income to shareholders. So REITs focus on sales leaseback arrangements. So that is, they buy a nursing home's property and lease it back to the operator. The leases typically have clauses that increase rent, say 3 to 5% annually, or they may tie it to an inflation index. The nursing home operator pays all the expenses of the property, including real estate taxes, building insurance, and maintenance. And there are two types of REITs. So now the most common is called a triple net leasing agreement. So this is a standard tenant-landlord arrangement. It protects the REIT against annual increases in property taxes, insurance, and maintenance costs. As I mentioned earlier, these are the operator's responsibility. Importantly, tax laws prohibit REITs from providing medical services in nursing homes under this structure, under the triple net structure. However, in the other structure, which is referred to as a RIDEA arrangement, that's RIDEA, which stands for REIT Investment, Diversification, and Empowerment Act of 2007. So under the RIDEA structure, this allows the REIT to collect taxable revenue for resident care to an eligible subsidiary. So it may be a separate company under from the REIT, but they may be owned by the same parent company. So under this structure, the REIT also often collects management fees and provides incentive payments for profitability goals. Again, this is under a RIDEA structure. Now, since a REIT is a separate entity from a nursing home operator in both the triple net and the RIDEA arrangements, it limits the impact of financial losses or litigation. Now, as with private equity, there are also potential pros and cons of REIT investment in nursing homes. So among the potential benefits, REITs provide an infusion of capital that can conceivably be used to improve and maintain facilities or to provide additional resources for patient care. These arrangements may also allow the operator to collect resources to allocate resources across facilities. So you can imagine if you have two nursing homes and nursing home A is performing well, and let's say you sell the property to a REIT, you could then use those resources to then improve the care in facility B. REITs may also provide operational expertise. They can facilitate group purchasing and provide access to proprietary health information technology. These investments may also allow the operator to focus on marketing and resident care. Among the potential cons, so REITs are incentivized to generate profits for shareholders as they're for-profit entities. It's also annual rent escalations may become unaffordable, particularly in times of high inflation as we're seeing now. So nursing homes that have a high percentage of residents covered by Medicaid, for example, may be particularly vulnerable, as Medicaid reimbursements often don't cover the full cost of care for residents. So these factors may reduce resources available to the operator, leading to lower quality care. So our research has shown that REIT investment in nursing homes is associated with slight increases in staffing levels of licensed practical nurses and certified nursing assistants, But most deals also lead to a decline in staffing levels for higher skilled registered nurses who tend to be who are more expensive to employ. But the impact on quality and costs for residents is unknown at this point. So there's a need for more research in that area. So I'll just go over a couple more points and then I'll pause for questions. But in closing, I'll briefly color policies and recommendations that have been made to increase transparency and accountability in nursing home ownership. So shortly after last year's State of the Union address, the National Academies of Sciences, Engineering, and Medicine issued a report with recommendations to improve nursing home care that included increasing transparency and accountability and ownership. So I'm currently working with an organization called the Moving Forward Coalition that has since formed with the goal of creating a blueprint to implement these recommendations. The coalition includes authors of the report, as well as stakeholders such as resident and staff advocates. So I'm happy to talk more about their efforts. Additionally, in just the last several weeks, the Centers for Medicare and Medicaid Services has proposed a new rule to increase transparency and accountability in nursing home ownership. Initially, I was elated to see this. However, after a closer look, the new rule as currently proposed does not include mechanisms to ensure timely and accurate reporting. However, some states have proposed similar rules that may serve as examples of policies with better enforcement mechanisms. I'll also note that the Moving Forward Coalition is working on recommendations for the new proposed rule that would help ensure timely and accurate reporting of ownership. So I'll stop there for questions, but thank you again for inviting me to speak today.
Okay, thank you. We'll go to the committee. Does anyone have any questions? You can just raise your hand.
All right, I see two people. Should I call on them or?
I'm looking for, well, I don't see them on my end, but one person can go and then we'll go for the next.
Okay.
Jamie, you could go first.
Oh, thanks. Thanks, Harold. The question I have is with this Moving Forward Coalition, are there any agencies that we may be familiar that are members or of the Moving Forward Coalition that could make recommendations to states on potential gold standard policies?
There may be. There are some, there's representation from unions, for example, SEIU. There are some former state officials. I don't know if any are from Missouri, but the membership is actually posted online. If you Google Moving Forward Coalition, you can see who's on every committee.
Okay, thank you.
Sure.
Okay, the next person.
Laura, you could go before me, sorry.
Okay, great. Thank you so much. That was just really enlightening. And I know you took us through it at a very quick pace, but it made a lot of sense. And it's also stuff that we have observed time and again in terms of how these shells are set up and nursing homes end up with, 4 or 5 or 6 different entities that, especially in the for-profit. And we've also observed a lot of for-profit nursing home chains and other owners moving into our area. And that was one of the things that prompted this committee. So you were right on point. So thank you very much. Really appreciate that. My question is, do you have a specific improvement that you'd like to see on that federal rule that would make reporting better? Because we really think that federal rule is super important. It's the first time we've had movement on something like that. So let's fix it and make sure it's as good as possible. I just want to get your perspective on that.
Yeah, so I think this is a wonderful opportunity. And certainly with the Moving Forward Coalition, we see this as momentum to make change right now. So the timing couldn't be better in that sense. But yeah, I think the key there is the having auditing done to ensure that there's accurate reporting and also having some sort of teeth to the rule so that there's enforcement. So right now, for example, ownership is supposed to be reported in a system that's called PECOS, P-E-C-O-S, that you may be familiar with. I can't remember what PECOS stands for off the top of my head, but essentially you have to be enrolled in it to be paid by Medicare or Medicaid. But where if you have a 5% ownership stake or higher, it's supposed to be noted in PECOS. how often when PECOS is not available to the general public, even for researchers, it's rarely available. But we were able to get access to it. And we found a lot of inaccuracies, actually. We found that most of the REITs, for example, real estate investment trusts, weren't reported in PECOS. So, but there's no regular auditing, and there's no real penalties for not reporting up-to-date information. So I don't want to see those mistakes made with this new rule. So I think there needs to be some way that it's audited, and there needs to be real teeth, whether that's heavy fines or some other enforcement mechanism that really makes sure that accurate reporting takes place and in a timely manner. And most importantly, I think all this needs to be easily accessible to the public. And by accessible, I mean it needs to be easily interpreted by the average person. Just saying they have a 5% ownership stake or more is not that meaningful to most people.
I think that answered well. I was just going to ask sort of recommendation. I think that answered well my question. I mean, I guess while we're here, you did talk about transparency. Do you have any other thoughts about regulations outside of transparency that you might think about that we could possibly implement or recommend?
Well, as mentioned earlier, related parties and related party transactions. And I think the way we're looking at this through the Moving Forward Coalition is transparency is the first step to accountability. And, so along with transparency and ownership, we want to see the related parties. And we'd also like to see where the money is flowing, since the vast majority of the revenue that goes to nursing homes comes from public funds through Medicare and Medicaid. We should know where those public dollars are going. So, I'd like to see, who's doing business with these facilities, who owns them, if they're related to the owner. And, they're supposed to charge each a market rate when you do business with a related entity, but we don't really know if that happens. So all around, not just in ownership, but also in these transactions, I would like to see more transparency as well. And I think that would also have there's always a debate about the level, say, of Medicaid payments. So in many states, they're very low. As I mentioned earlier, they don't cover the full cost of care. But there's also reluctance to increase payments to nursing homes or to make other resources available if you don't know how the money is being spent. So I think by increasing transparency and knowing where those dollars are going would also create opportunities that would allow maybe improvements that might move away, for example, from the traditional nursing home structure. It's sort of based on a hospital model, maybe something like a small home model or other models that have been proposed for long-term care.
Andrew Lackey, did you want to speak?
Yeah, I just had a question about, you said that the primary kind of one of the primary motivations for some of this is the actual land that the nursing home sits on, and that the REITs will then sell the land. But then, I mean, I wouldn't, I mean, but I would think that the actual structure, where the nursing home care takes place, if you sell that, then you've essentially sold the nursing home. So do they sell everything around the nursing home? Do they chop it up into lots? How does that happen?
Well, I think both of those things are true. So with private equity firms, well, with ownership in general these days, there's been a trend into sort of separating all the assets into different entities to limit liability. So it might be in the clearer sense, you're separating the real estate or the facilities, the land and facilities, from the operations. So that limits liability, for example, if you're sued. But you could also put, say, all the durable medical equipment into another LLC, and other assets into other sort of shell companies, if you will. But often what the private equity firms do is once they acquire a nursing home, they'll sell off the land, and they'll take those proceeds, or the land. When I say the land, I mean the land and the facilities. They'll then take the proceeds from selling off the real estate and give that back those funds to the investors. They don't go back into the facility. But now you have a situation where the operator has to pay lease payments on top of all their other expenses, which they didn't have to do before. And if you also remember that often private equity firms put the debt, when they acquire a facility, they put the debt on the nursing home, not on the investors. So they also have that expense. So those are a couple of things to keep in mind. With the REITs, their whole business is the real estate. So they typically buy the facility, and under the most common structure, which is called the triple net structure, they're not involved. They're not supposed to be involved in operations. However, they may still have someone on the board of the nursing home. And that arrangement sort of relies on those two groups not talking to each other, which I'm not sure you can guarantee. However, under the other structure that I mentioned, which is called RIDEA structure, I know there's a lot of terms I'm throwing out here, but under the RIDEA structure, they can actually be involved in nursing home operations through a related subsidiary. And that sort of gets at the issue we were talking about earlier, where now you have these related entities doing business with each other, and it's not transparent. But in that case, you then own the land, and then you're also involved in the operations. So there may be other changes beyond just leasing the property back to the operator in that case.
Anybody else have any questions? Because I don't see any hands up. It's not a question, it's really a comment, because I agree with what Mark is saying, and I'm speaking from experience. And so I do know, I did work in a nursing home environment, and the owners started adding like physical therapy, and they had a company where you get supplies from it, but it was all within them in that group. And so I don't think people even understand how they logistically try to manage and control that whole nursing home venue by adding and putting things on to there. So it's like, it's not them, it's another entity, but it's actually them.
Mm-hmm.
And so I agree, we do need to have more transparency. And I hear people say transparency, but I want to know what people thought so when they say transparency, because some people say transparency, but it's only for their convenience and it's not really transparent.
Mm-hmm.
So that's an issue with me too, also. Mm-hmm. So did anybody else have any questions or comments for Mark? Okay.
I may have missed
sorry.
it. No, that's okay. I may have missed it, Mark. So who's holding who account? Because because it almost sounded, in a sense, and maybe I'm getting it confused, that it's almost like a self-governing thing, and there's nothing holding these private investors accountable. If you could help us with that. Thank you.
Yeah, sure. I mean, there are, obviously regulations that any nursing home operator has to follow. And you also have, things like public reporting through the 5-star ratings, through Care Compare as examples. But in terms of sort of what's going on behind the scenes in terms of the financials and so on, it's a black box. You just don't know what's happening there. So, I don't want to make it sound like all private equity firms are the same and all REITs are the same. There are probably some good actors and bad actors. We've interviewed some, and some of the large representatives from private equity firms, and some of them are very concerned about their reputation. They don't want to show up in a story in ProPublica talking about how their nursing homes have harmed people. And they get really frustrated with other firms that don't have that same view, and they're just trying to extract as much as they can from the facility before they sell it off. But yeah, there really is very little known, and it's hard to enforce actions to make changes in terms of the financials anyway, without seeing what's going on.
Okay, do we have any more questions for Mark?
I'm sorry, I just have one more quick one. Do you have any recommendations for what we can do on the metropolitan level that will make a difference?
Well, I'll be perfectly honest. I'm not as familiar with city and local regulations, but I imagine you could use states as examples. So, for example, recently Pennsylvania and New Jersey have proposed new rules to increase transparency and accountability. And I know a while back California did as well, but I'm not familiar with what they proposed and tried to implement, but I've heard some concerns raised about not being as effective. But I know there is a lot of interest in what Pennsylvania and New Jersey are doing. So that might be a good place to look. Likewise, in the Moving Forward Coalition, we have someone from Maryland. And Maryland, each state has its own cost reports as well. And apparently they include a lot of information on the cost reports that isn't, say, included in Medicare cost reports, for example. So that might be another place to look.
Okay, thank you. Do we have any more questions? Okay, Mark, I don't know if you have your presentation in written form, but if you do, could you please send that over to the clerk?
I didn't actually have a presentation. I just had some notes scribbled. I'm sorry.
Oh, okay. Okay. Well, thank you so very much.
Okay, thank you for having me today.
Thank you. We will now move over to Tracy Niekamp.
Great. Good afternoon, everybody. Thank you so much for having me. So my name is Tracy Niekamp, and I am the Assistant Administrator for the Section for Long-Term Care Regulation. The Section for Long-Term Care, we are within the Department of Health and Senior Services, and we regulate long-term care facilities across the state. So we currently license around 1,150 long-term care facilities across the state. We have those homes divided out into 7 regions, and St. Louis City is in what is our Region 7 office. So we actually have an office building on Olive downtown of St. Louis. So in the Section for Long-Term Care, we have 4 different levels of care. The first are just state licensed only. So there's no Medicaid or Medicare funding that goes specifically to pay per diem or per day rates in those facilities. They're typically more private pay. And so residential care and assisted living in St. Louis City, you have 25 locations. And then your typical, like Mark was talking about with nursing home compare and some of the CMS requirements, those are skilled nursing facilities. And so they accept Medicaid and Medicare reimbursement for services that they provide. And you have 17 skilled nursing facilities, but it's a little over 2,200 beds. So that's quite a few beds for the number of facilities that we have in that area. So in our office in St. Louis, we hire both registered nurses and non-nurse surveyors. And a typical, I think we'll just talk about a typical skilled nursing facility process just for time. So typical skilled nursing facility, a health survey, we typically will have 3 to 5 staff who are there for a full week conducting a survey. They review everything from quality of life, quality of care. They also look at kitchen sanitation, resident funds, staffing, just a variety of issues that they look at while they are there. Typically, it's about a week long. Also, while they are on site, we have staff that also do an environmental review for fire safety. So that's called a life safety code survey. And then also we have staff that also do an emergency preparedness review as well. So taking a look at the facility and how well prepared are they for any type of emergency that maybe could happen. And that could be anything from a loss of heat to a potential earthquake, depending upon where in the state they lie. So we have multiple staff in our St. Louis area that perform that role. We also conduct complaint investigations in each of those facilities as well. So just to give you an idea, we are seeing a large increase in the number of complaints that many of our long-term care facilities are receiving across the state. And most of that, as you can imagine, is related to staffing. And so we are having a difficult time, many of our long-term care facilities, with being able to attract, hire, and retain registered nurses, licensed nurses, and certified nurse aides. Many of them have gone to work for agency staff or have kind of gotten out of the business over the last couple of years. And so that has been a challenge for them, and that is something that we are seeing on our end that impacts the quality of care and the quality of life for those residents. So I wanted to kind of go through a little bit of what happens after. So let's say we go to a long-term care facility and we have identified that there has been deficient practice. So perhaps there's a care area where we have identified they are operating outside of the regulations. We issue what's called a statement of deficiency to the facility, and then they're required to submit a plan of correction to us that details how they are going to correct that deficient practice, not only for the residents that we sampled in the facility, but then any residents who could be similarly situated as well. So let's say we cited maybe 2 residents in a facility that had issues with pressure ulcers. The facility would need to then review all residents in the facility to make sure that they are doing corrective action for everyone in the home that could potentially have that issue. And then after that, we do a revisit to make sure that they have actually achieved compliance. So we're looking at how have they trained their staff, how are they contacting their physicians, how are they making sure that their systems are in place to make sure that deficient practice does not occur. Statewide, we are seeing increases in the number of what we call immediate jeopardy complaints. And so those are oftentimes abuse and neglect complaints, or complaints where we are seeing very serious outcome or potential of serious outcome for residents as well. And so there's kind of a separate enforcement process for them. When our staff go in, they're wearing 2 hats. They're wearing a state hat, and so they're looking at state regulations, but then they are also wearing a federal hat as well. There are numerous federal regulations. If you printed them out, they would be about a ream of paper that facilities are required to follow under the federal regulations as well. And so when our staff go in, they're taking a look at both the federal regulations and the state regulations while they are reviewing particular situations. There's 3 main components of any process that we do, whether it's a complaint investigation or a survey, and that is observations. So making observations of residents or the environment, the care that's being provided. Interviews, and so that could be interviews of the residents who live there or their families, the staff. So observations, interviews, and then record reviews. So taking a look at any of the records, so whether that's patient records or that is inspection records. So those are the 3 main components of our process. In addition to that, our section also runs the certified nurse aide registry. So any individuals who want to become a certified nurse aide, that information, that process trickles through our section, in addition to level 1 med aides, which provide care in residential care and assisted living. We have engineers that review plans prior to a facility being built and licensed or certified. So we have engineers who take a look into all of the blueprints, and that's actually for hospitals, ambulatory surgical centers, long-term care facilities, etc. So I'm going to pause there and see if you guys have any questions or Chairwoman, if there was anything that you were hoping that I would cover that I have not, please let me know.
Okay, thank you. So, Laura, you have a question?
I do. So we are wondering, Missouri and Illinois are at the bottom of the heap in terms of the number of staff hours to residents. You know, quality of care is just absolutely essential. It's essential that we have enough adequate staff to actually carry out the care plan that is needed for each resident. When we're so consistently failing as a state in terms of our nursing homes, it just makes me wonder how can this go on for as long as it's gone on? And I know, Ms. Niekamp, this is not your personal fault, and I'm not trying to blow you up.
Right.
But, we've got a lot of folks, I'm with SEIU Healthcare, we've had members who have died. We've had so many residents that have died, and we're pretty frustrated with the state of inspections. The other thing I'd ask is, how behind are you all in terms of the number of inspections that need to be done? I've heard that, all kinds of, numbers in terms of you're a year behind, you're 2 years behind. I'd love to know some more about where that is, and then what the plan is to catch up in terms of catching up on inspections. So how can we increase the quality of care here in Missouri, and what's your plan to do that? And then also, what are we going to do in terms of getting caught up on inspections?
Sure. So let's start first with staffing. So in the state of Missouri, and actually in the federal regulations currently, there are not minimum staffing requirements for providing personal care. So we do have some minimums for fire safety, but that is not the level of staffing that would be needed in order to provide good personal care. That is very independent upon each facility. So if I have, let's say I have a 50-bed facility, and most of the individuals in that 50-bed facility are able to walk on their own, they're able to provide for their own ADL care and only need verbal cues or reminders. The level of staffing that I need to provide care for those 50 individuals is very different than if I have 50 individuals who reside in, who typically are bedbound and require extensive assistance. So when we are looking at staffing, we very much have to look at what's the acuity of the individuals that are there. So what are we doing in order to help the current staffing situation? So there's actually two different bills currently going through the legislature right now to increase the certified nurse aide pool in the state of Missouri. And so that is one thing that we are looking at is being able to reimburse facilities at a higher level for their training of those nurse aides. And then also there's a separate one for technical centers, so technical schools and career centers that are able to provide that training as well. So that's one way that we're hoping to increase the certified nurse aide pool. One of the things that's been really difficult for facilities has been the way that they have had to rely on agency staffing. So the Sinclair School of Nursing in Columbia recently they are working on an abstract regarding just the staffing levels in long-term care and where we were in 2019 versus where we are now. And when you look at the number of facilities that relied on agency staffing in 2019 versus the number of facilities that require agency staffing to provide basic care now, it's staggering, just the amount of homes that are requiring that agency staffing. And that's just to provide the basic care. A lot of homes have had to stop taking new admissions because they don't have the staff to be able to provide the level of care that they want to provide. And so then they have had to stop admissions, which has had a trickle down effect then of hospitals having difficulty in being able to release residents or release individuals into long-term care for that continuity of care, right? And so it has been difficult. Another thing that has been done as well is that Medicaid has looked at the way that they reimburse facilities, and they are going on currently, or back last year, they were you received a per diem, and it was not based on resident acuity or the care that they needed. It was just basically you were built during this year, and this is how much we're going to reimburse you per, it's based on their cost reports. And so this is what we are going to pay you. But in no way, shape, or form actually met what those costs are. And so oftentimes what you would see is that homes would limit the number of individuals that they have in their home who have Medicaid reimbursement, because they just simply couldn't afford to pay. They couldn't afford it to have, they had to have a mix, kind of a case mix of individuals that were Medicare, Medicaid, or private pay in order to make their bills at the end of the month. So Medicaid has submitted to the Centers for Medicare and Medicaid Services a plan for taking a new look at the way that we provide Medicaid reimbursement, and that is on a case mix basis. So it's looking at what is the acuity of the individuals that are there, and the specialized services that are being provided to them. So CMS is reviewing that, and hopefully that will help to ease some of the financial strain that a lot of the homes have had, so that hopefully they can pay better wages to be able to retain and attract more staff. So Pamela, did you have a question?
Oh, no, I'm sorry.
Okay.
You look, I'm having flashbacks, so I'm okay.
Okay. All right. I saw your name pop up. I thought maybe you had a question. So essentially that is the difficulty, and that is what a lot of facilities have been communicating to CMS. As Mark said, and then I think Laura put in the chat, CMS is working on some staffing requirements for skilled nursing facilities, but what homes have indicated is, the difficulty that they are currently having in retaining and attracting staff, and they're very unsure what those staffing measures will look like for them for that minimal staffing. So I don't know that. I think, Laura, that covered all of the questions that you had asked. It's difficult, right? We would like to be able to have, some minimal staffing requirements, but minimal staffing requirements are just that, they're minimum. And so truly it's, how do we get to a point where it's not just minimal staffing, it's truly sufficient staffing to be able to provide good quality of care. One of the things Mark had talked about earlier were also some of the different models of care, like moving away from institutional to more of the house or like the cottage type environments. And that increases the amount of staffing that's needed for those settings as well. So if you have, a 10-person cottage instead, if you have 10-person cottages instead of 100-bed, institutional type facility, you have to have sufficient staff for each of those cottages instead of that one, that one building that you're providing care for. So homes have to kind of take that into consideration as well. So I think Lavetta had some questions first.
Yes, ma'am, Ms. Tracy. One question I have, but I've been working at nursing homes for the last 15 years.
Mm-hmm.
And my question is, what can the state do to encourage nursing homes to go above the bare minimum?
Great. So that's a great question, Lavetta. So first, thank you for your many years of working in long-term care. I've worked in long-term care for a little over 21 years, so I appreciate you very much. So what are we doing to help incentivize facilities? So unfortunately, the way that regulation and compliance is created, it's more of a punishment. There's more punishment, I think, than there is reward, unfortunately. So the way oftentimes that CMS or the regulations, the way that pans out is, if you haven't met this minimum, then this is going to happen to you. So if that could be civil monetary penalties or a variety of, denial of payment for new admission. So oftentimes it's more of a reactionary than it is proactive. I say that, but then also there are some things in the state of Missouri that we have been able to do over the last 20 years to help long-term care facilities. And one of those has been a program called QIPMO. So it's Quality Improvement Missouri. And it is free resources to skilled nursing facilities that when they have identified that they have a clinical or an administrative question or concern, that they can reach out to those QIPMO nurses and leadership coaches, and they can come on site and provide free hands-on assistance to facilities to help them improve their quality of care. That QIPMO program has been funded by civil monetary penalty money. And then also through nursing homes in Missouri have to pay a bed tax. So on all of their Medicaid beds, they have to provide, they pay a tax. And so a portion of both of those funds go into paying for QIPMO to provide those free consultative services. And that's available to any skilled nursing facility. So that is one, good thing I think that we provide. The other is that outside of the regulatory process, Shelley Williamson, our administrator, and myself, we provide a lot of education and outreach to administrators across the state to help provide education to them on new CMS initiatives, new regulations that have come out. And try to work the best that we can with the long-term care associations to make sure that we have good communication, with them. And I think a good testament to that was during COVID, when we had to have a lot of really difficult conversations with those facilities. But so those are some of the things, Lavetta, that I think, how we have been able to help. So, Marjorie.
Hi, Tracy. I'm Marjorie from Voice. We host the Ombudsman program for the area. I was taking a look at the some of the CMS data from Q3 of 2022 that the Long-Term Care Community Coalition wonderfully makes usable. And I noticed when I'm looking at contract staff percentages for the places in the city of St. Louis, I will say from that quarter anyways, the state of Missouri had an 11% usage rate. It looked like about 11% of our hours were contract, which is a lot. I'm noticing that the facilities that are traditionally our 1- and 2-star facilities here in the city have 36%, 63%, 63%. But then we have some that are 0% and 6%. So I'm kind of wondering, is there anything that what can we do to help that? Because it seems like it is certain facility, and it does seem like there are lower ranked facilities as well. And that's certainly a concern. I know that means that the staff aren't getting to know the residents, which can lead to lower quality care. What could be some fixes to some of those sorts of things?
So one thing to remember with the 5-star quality rating system is that the staffing directly relates to the stars, right? So if you have less staffing, it's directly going to result in your stars. Typically, you're not going to see a facility with a high level of agency staff who are also 5-star. Like just the recipe or the technical, manual for how they calculate those stars is going to impact that. But as far as, what can be done in a long-term care facility to reduce their dependence upon agency staff, I think the top thing is that whether it's a long-term care facility or your organization, right, that you are currently working in, it has to start from the top down. So having consistent administration. So what we see oftentimes is that, facilities could have 3 different nursing home administrators in the span of a year. And so that inconsistency oftentimes leads to staff being inconsistent as well. We talk about agency staffing. To give you a real life example, I was presenting, or Shelley and I were presenting at the Missouri Healthcare Association earlier or last week. And one of the staff or one of the administrators that was there said that they are currently having to pay agencies $34 an hour for a certified nurse aide. So, those are things that you cannot sustain that, right? Like that is not a level that they can sustain, but they're trying to put a Band-Aid on it just to be able to get to the next day. And so I think that is a question, Marjorie, that absolutely every state agency and every facility are asking themselves is, how do we stop the bleed? How do we, what do we do differently? I know there's been several organizations, including the Ombudsman program or your national organization, that has been looking at, how do you retool the way that people think about being a nurse aide, right? Like, how do you make it a profession that perhaps people continually grow, that they continue to grow in that profession? So some of the best administrators I know started off as kitchen help when they were 17 and then became certified nurse aides and then attended RN school or became a licensed nursing home administrator. They grew up in that era. And I think that that's something that we don't see a whole lot of young folks that are graduating high school or who are in high school. And so one of the things that we have been looking at is with the new proposal, the new legislative proposal with the funding, in looking at, are there ways that we can grab on to those individuals in high school and get them really interested in long-term care in high school as certified nurse aides, and then grow them in those positions. But I think that's something the hospitals are looking at. The staffing crisis isn't just about long-term care. Hospitals, home health, hospice, everywhere that employs, people taking care of people, they're all suffering. So.
And then I've got one other maybe unrelated question. So I know that our team is often giving out the hotline number for DRL based on just things that we the Ombudsman program can't fix right away. Do you have any idea how many calls like that you guys get a day or month or year?
I do. So so just to give you a good example, in the year 2019, so before COVID, we had right around 9,000 complaints a year. And this last year, so this last calendar year, 2022, we had 11,400, I believe. So the numbers are huge. And that is what's keeping us from being able to get some of our survey work accomplished, because we are constantly investigating complaints. So you can imagine with 11,000 complaints and close to 1,200 long-term care facilities, I don't have enough staff to be able to make all of my timeframes, to be able to, I think Laura had the question about when are you going to get back to normal? You know, when are you going to be able to get all of those surveys accomplished? We are working hard to get done what we are able to. We also this last year did get some additional funding. It was one-time funding from the Centers for Medicare and Medicaid Services to help us to be able to enter into a contract with a couple different agencies to do contract surveys for us. So to be a long-term care surveyor, it takes about 2 years of training and you have to pass a federal test. So it's not like I could hire any of you just off the street and say, okay, I want you to go do a complaint investigation at this facility. It takes about 2 years of training for you to be independent in being able to do that work. So, so with our high numbers of complaints, to give you another piece of information, our immediate jeopardy complaints, which are our priority A complaints, we are required to be on site within 24 hours. So if somebody calls in a complaint and they say, my mom was abused, you know, this nurse aide came in the middle of the night and hit her, my staff have to be on site within 24 hours. We saw an increase in calendar year 22 of 194% of our abuse and neglect complaints. And we think a lot of that is related to the use of agency staff, you know, just, you know, folks being put into a situation that, you know, agency staff do not know residents as well as staff who have worked with them every single day. And so anyway, so our priority A complaints are up a huge amount as well. So we are hopeful that, you know, we just continue to make progress. I wouldn't even give a guess on when we think that we'll be caught up, just because there's so many unknown variables for us right now. But just know that we are working really hard to be able to get all of those abuse and neglect complaints reviewed, and to get those surveys done as well.
Okay, thank you. Alderwoman Boyd, I saw your hand up.
Chair Middlebrook, I think she had to attend another meeting.
Yeah, sorry.
Oh, okay. All right, is there anyone else with any questions? You can jump in at this moment.
I guess I would
Okay.
I'm sorry, I guess I would just push back a little bit on we don't know how we're possibly going to get caught up on inspections. It seems to me like this is a real crisis that we're experiencing right now for the state of Missouri, and people are dying, you know, or early basically, because they are not getting the care that they need. I hear you, and that there's like tremendous dysfunction, and that there's all kinds of, you know, barriers that are in the way, including Target and Amazon are paying a lot more money. You know, there's all kinds of things that are structurally making this a very difficult problem to solve. But it is, you know, our problem to solve. We have to be able to point to something that says, in 5 years, in 10 years. And I do understand we also don't know exactly how this virus is going to behave. And so that's
what I can say, Laura, is that in our current state, we are not sure when we will be caught up. But we have requested additional funding from the Centers for Medicare and Medicaid Services for additional contract surveys. We have asked for additional funding from CMS in order to be able to pay our nurses a wage that we can help retain. So currently in Missouri, we have 180 nurse positions, and I currently have 25 of those vacant. And so just trying to hire nurses and being able to retain them. We've asked for additional funding from CMS. We have had a flat budget since 2015 from CMS, although we've been asked to perform additional survey duties. We also, just to clarify, just because we haven't been in a facility in order to do a survey does not mean that we have not been in the facility. So we also are required to do focused infection control surveys, complaint investigations. There's very few long-term care facilities that we have not physically been in the last year because we have, you know, such a volume of complaints and other workload. So yes, we aren't just sitting back and saying, you know, oh well, we don't know when it's going to happen. We're taking lots of measures to try to improve upon our position to where we hopefully will be able to get back to normal.
Yeah, and I guess one more follow-up, Marjorie, sorry. I just encourage you to think about the wonderful people on this call who can all help you push for a strategic plan that will actually help to move us forward. So we've got a lot of concern. There's a lot of families out there who are just, you know, really wanting this problem to be solved. So, you know, like, let's think about that together. And like, if you think a minimal staffing standard will help at the state, let's, you know, other things that we can help you push for, you know, let's think about how to do that together. I mean, the reason everybody's on this committee is because we're looking for a solution. So we'd like to work with you to figure that out. So I don't mean to be antagonistic. We've just got a lot of feelings bottled up. So I'll turn it over to Marjorie.
So, okay. So when Biden announced all of the great things that they were hoping to do for nursing homes last year, I think one of the things they mentioned was more money for surveyors. And I think you may have answered this question, but has that money come through at all from the federal government, or is it still on hold, or do you have any idea what's going on with that?
So as far as, so our salaries, so state salaries for surveyors, it's a combination of federal and state money. So anytime, so other than this most recent raise that the governor or that the legislature approved, that 8.7% was all covered by general revenue. So that will all be covered by state money. Prior to that, however, anytime there was a raise, let's say it's $100, like if they were going to give you $100, then I had to have $80 of federal money to come on and $20 of state money in order to make up that $100. So the federal government has not given us any additional funds since 2015. And so we've had to make that up on the state side. So we are not flush with cash. I always tell people, I'm like, we're living on a fixed income, you know, in the section for long-term care. Like you can't overspend what you have, right? And so no, we do not have any additional funds for surveyor salaries other than what the state government has provided. And we are so incredibly thankful for that, because that will definitely help us, especially in some areas of the state. But we did receive, as I said, some one-time funding from CMS that allowed us to enter into a contract with 3 different staffing agencies to provide some survey work. Now that was very short-lived. It was only 2 months, I think, and they conducted 13. Shelly's sitting here with me. She popped in. So 13 surveys. So we were only able to get 13 surveys out of the contractors before our time limit ran out for that funding to be used. but we still have our contracts in place. And so as soon as they give us some money, we have a list of facilities that we are ready for them to get to. And many of them are in the St. Louis area, because that is definitely where we are struggling. The St. Louis City, St. Louis County, St. Charles County area historically has been the area where we have struggled to be able to keep up with our complaints and to make headway on our surveys. But I mean, we're struggling statewide, but those are the areas that we have the most difficulty, just because of sheer volume of complaints. Great.
Okay, is there anyone else who may have a question or comment for Tracy?
I do have one quick question. I just wanted to clarify, Tracy. So with this particular, the information that we gathered at the very first meeting was that there were these few nursing homes in the city where there was raw sewage coming out of the sink. There was bed bugs, and many of the people were impacted by bed bugs. Is that a state issue? Is that a local city health department issue? Who takes jurisdiction over these issues, and why is it still going on?
Right. That's a great question, Jamie. So I think it's both. It's both an issue. So for the city, you guys typically have your own health department rules and regulations separate from our rules and regulations. So if you have situations like that you're aware of in a facility, please make sure that rather than, so in the, Laura, I'm going to ask you to email me the specifics that you have so that information can be put into a complaint instead of in the chat box. If there are specific issues, we can go out and do a review and get those things taken care of. The thing to think about with bed bugs, so a couple of things with bed bugs is that you really have to look at what is their preventative process and their taking care of it process, right? So once you get bed bugs, a lot of the time they're extremely difficult to get rid of. They're really expensive to get rid of. And so it may take multiple treatments in order to get those things. To get all of those things taken care of. So essentially though, to answer your question, Jamie, sometimes it's a combination. And so you guys should definitely address those issues from your ability and your regulatory authority. And we too can take care of it in our regulatory authority as well. But yes.
Okay, is there anyone else who has a question or comment? Going once, twice, and three times. Okay. Seeing that there are no more questions or comments, Tracy, thank you so very much. You gave us a lot of helpful information. We do appreciate you.
Thank you, Lisa.
Okay, so next up, everyone, I am pretty new to this committee, so former Alderwoman Ingracia, I'm not for sure how she went about with what's going to be heard at the next meeting. Does anyone have any suggestions or input on what the next meeting should contain? Who should be here? Harold?
I do have ideas, but I have a question first. So I think Alderwoman Ingracia, this was going to be the last meeting, I believe, where we were going to have speakers in, because we were presumably going to start writing the report for,
Okay.
I forgot the exact date. It was like in the middle of April or something like that. But she had also mentioned via email to me that maybe there's an opportunity to extend that, which I would welcome. But I don't know about other people's things. So when do we need to get something to someone by? And what is it?
I will get that information out because I'm not for sure at this moment. I will have to have more conversations with former Alderwoman Ingracia to get clarity on where we are with this committee. She couldn't attend today, but I will contact her to find out if we need more meetings. I am not opposed to having more meetings if that's what you guys want. Laura? I'm sorry, you're on mute.
Okay, we had a
There you
couple
go.
of speakers that scheduled for the last two meetings, which we could reschedule if we wanted to go ahead and have another meeting next week and the following week. And perhaps even the week after. We had Nina Cohn from Syracuse University, Marjorie Moore, obviously from Voice, Andrew Wang, who's going to explain to us about mapping, Theo Kleist, who's a resident from Hillside, Nathan Dell from Places for People, and Richard Mollett from the Long-Term Care Coalition, who also is part of that whole moving forward movement that's going on. Both Nathan and Richard have their presentations all ready to go. I know for sure, I imagine Marjorie does as well, and Miss Professor Cohn. But I think if we had a couple more meetings, it'd be great to just go ahead and reschedule those folks and hear from them, because I think they've all got something to offer that could be really valuable. But yeah, understanding when we need to do an interim report and then the full report would be super. I think if this is reintroduced into the board, the next session of the board, that gives us a little bit more time to actually pull together the report, which would be great. On the other hand, we all know this is like, urgent stuff. So, I also want to see our committee move into action as well. But yeah, I think if we could hear those speakers and then start talking about an interim report, that would be wonderful, and figuring out where we're going next on that.
Okay, thank you, Laura. Can you send that list of people over to me so I can have
That'd be
that?
delighted.
And we
Yeah.
can schedule a meeting for next Monday at 3:00 if that works with everyone, and then the following week as well. Jamie, you have your hand up?
Yes, thank you, Alderwoman Middlebrook. Cassandra Kaufman, the executive director for the Mental Health Board, was also interested in being someone on the panel to listen in, because of so many people that are being placed into nursing homes with severe mental illness. And so I didn't know if we could send an invite to her. We share an office space, and I was telling her about what we're learning.
Okay, absolutely. Can you send her name over to me so I can make sure we add her too?
Absolutely, thank you.
Okay, and let me see if we have anyone else with their hand up, or if you just want to jump in, that's fine.
I think it's Marjorie again. I think based on even Jamie's last question, I would love to hear from somebody, and I don't know what department this would be, but somebody within the city who has the ability to go in and look at especially these physical plant problems that the facilities have. I mean, we have one that I know they burst a boiler at Christmas time, and then the pipes broke, and so all the residents are out of that facility. We mentioned, the one with sewage problems and bed bugs, and I know that we have a lot of fire code violations from the most recent inspections for the facilities. I'd love to hear from somebody from the city who, is responsible for that piece, because I think that may be a way that we can propose some fixes. I mean, I don't know if we can fix agency staffing, but if we can fix the physical plant, that's going to make a big difference on those who live and work in the facilities.
Okay, I will get in contact and see who we can get to come in from the city level. I think that's a great idea, to come in and talk about the complaints regarding, I guess, building issues, such as the sewage and the bed bugs, and different complaints regarding the facility. Is that okay?
Yeah.
Okay. All righty. Okay, anyone else?
I just want to
Harold?
say, yeah, I arranged for Andrew Wang and Nina Cohn to come here. So if, you do want me to, I'm happy to reach out for them to reschedule it. I think right now, maybe I'm going to wait till next week. Let's meet and get a sense of what our mandate is and what the time frame is. And then I could reach out for them after that. Does that sound okay?
Okay, and the two people, I'm sorry, their names again?
Nina Cohn from Syracuse and Andrew Wang from University of Kansas, who's a geographer.
Okay. All right, that sounds like a good plan. And possibly we could have two other people come next week to discuss different issues, and we could have them come the following week. Okay. All right, everyone. I want to thank everyone for bearing with me. This is new for me, so thank you all. Madam Clerk, did we have anyone here who was not present?
Yes, we had several people that wasn't present today. Did you want me to name those on here?
Yes, can you please?
Okay, we had Alderwoman Davis. We also have Lenny Jones, and he sent a message stating that he wasn't going to be here today. And we have Danielle Spradley, Chris Beckley, Sasanya Johnson.
Okay, thank you. We want to go ahead and excuse the aforementioned people for necessary absences. And if they're, I want to make sure I'm doing everything, I'm sorry, that I'm supposed to have on my agenda. So if
And
there,
also Chair Middlebrook, just to make
Yes,
mention,
ma'am.
on the roll earlier, I called that there were 15, but it was actually 13 present.
Okay, thank you.
Mhm.
Thank you. So we have excused all the people. Okay, so I want to thank everyone for attending. It is now 4:26, so we're going to go ahead and adjourn this meeting. So everyone, please have a wonderful, safe week, and we will see you on next Monday.